Hello, hello, and welcome to another Pilates Hour. Am I super excited today or what to have Pam Downey with me? Some of you are familiar with her work and familiar with her long-term relationship with Polestar as an educator, as a specialist in women's health and pelvic floor health. We have enough people on here to get started. So what I'd like to do is before I introduce Pam, formally, I'd like to go to the Mentimeter, and we just want to get a pulse on your excitement and awareness of the topics that we are going to be talking about today. So as you do that, I'm going to introduce our guest. So Pam Downey and I go back, we met in 1998, I think, or 97. I had moved to Miami to get my PhD and to study at University of Miami. Pam was in the class ahead of me. We were classes of two people, so it was Michael and myself and you, and I just saw her this year.
Yes. Yeah, Cheryl Burdett, yes.
Cheryl Burdett. So I just saw Cheryl, and Cheryl has been teaching out in Colorado for almost 20 years now. But the four of us were all going through the program there, and very shortly after that, when I opened up the practice again, Pam was already in a practice called Partnership and Therapy that dealt with women's health almost exclusively. And we sort of joined at the hip, and you rented space from us, and you've been my go-to for women's health, pelvic floor issues ever since. Pam has a long, extensive background in working with the American Physical Therapy Association's women's health in the beginning. Now it's the Pelvic Academy of Pelvic Floor Health. And she was instrumental in things like the exam and the certification process. She continues to be a reviewer of papers and posters for the organization. She runs, I think, one of the best physical therapy practices in pelvic floor health and women's health, both, and we'll distinguish that a little bit for everybody. She graduated from University of Miami, and I think just looking at it's hard to believe it's been almost 25 years now that we've been colleagues in the profession, and I just can't think of anybody better. Pam is a faculty for, I'm going to say it wrong because I just had it written down somewhere, Herman
Wallace.
Herman Wallace. Herman Wallace, I got it right. And she also developed our curriculum for women's health years ago in Polestar, and we're excited with some of the updates and things that are going to be coming down the pipeline for us. So Pam, welcome. Good to have you here as always, and excited. Let's see what the population out there, community is saying. So primarily Pilates teachers, and again, the more you participate out in the cyberland, the more it allows us to be able to give you very specifics. I see over 100 people on live and 33 people answered it. So make sure you get on Mentimeter. We have one more question that actually is really important for us to get a gauge of how we're going to be talking about women's health and pelvic floor today. So get in there. I also saw that there were quite a few people that were both, so that's sort of cool. Pam, tell us a little bit about what you're up to these days. What's exciting you? What's new for you?
Well, I think really seeing how pelvic floor is recognized and the importance of women's health, pelvic health in daily wellness. I think that's a huge thing, and education is super important. And also, thanks for having me on. It's always great being with you, Brent, and the reach of Polestar is so great, and I love being a part of this. So just to send that shout out to you guys. I think the good and the bad is that there's a lot of buzz around the pelvis, pelvic floor, but then there's, like everything else, it gets a little diluted or a little translated. So I always like to come back to, well, what do we really mean by certain things? So that's one aspect of something that I'm really putting out there now is let's all have a similar vocabulary and understand really what we're after. And there's way more people coming via the internet, via, just interactions, more open-mindedness about how women are during the birth experience, for example, and coming and seeking services after delivery with different health professionals. And then the most people are coming into the system because of excellent trainers that are working with them, and they're picking up on dysfunction and then referring them appropriately. So that's what I get really excited about, is that it's really not a medical model as much, but the medical model is ready to embrace, but it's also out there both with educators and with actual people on the street.
Yeah, and that's such an important aspect of that continuum of care that we've always talked about. And a lot of times people get very territorial, right? So it's like the pelvic floor is my territory, my profession, my training. And what we don't realize is that it's a continuum, of health, just like everything is. It's like some point in time, they're going to go back and be doing home exercises, or they're going to be going into a gym, or they're going to be taking a dance class. And the more people that are aware in that whole spectrum of pre and rehab and post is super important to be able to, fully appreciate what all of our ultimate goal is, which is to allow people to participate more wholly in life. So if we're dealing with things like incontinence or pelvic dynia or weak abdominals and hernia of the abdominal wall postpartum, I mean, these are all things that impact people's well-being. And it might be, and this is what I love about our relationship, has been like, when I go through and I'm screening somebody, I completely understand the impact that a pelvic floor pathology can have on intra-abdominal pressure with somebody with low back pain. But I'm fortunate to have Pam in my circles of where, when I rule out pretty much everything that has to do with physiology and structure of the spine, I can say, narrow it down and say, I really think this person needs a pelvic floor consult. Can you look and see if there's something that I'm missing, in the body? And if you'd be able to come back and be able to test and see, do internal, external, use your eyes, your experience, maybe you're interviewing. It's not just the physical assessment, but it's the interviewing and the trust that might exist between a female therapist with a female patient that's having back pain. There might be other issues that do not readily come forward in the interviewing process. And so I think that, for us, just from a starting standpoint today in this discussion, is really embracing that continuum and the dialogue, and particularly in pelvic floor health, of removing the sort of stigmas and the things that are negative that often prevent us from talking about incontinence or pelvic floor pain.
Absolutely. Yeah. And you touched on something that's really important. In the healthcare model, a lot of our healthcare professionals that are seeing patients on the front line have just minutes with their client. And a lot of these issues are very personal. They may feel embarrassed or sensitive about it. And getting that across when you're visiting in that small amount of time, it doesn't always happen, or it doesn't come out the way maybe they wanted it to. And then when we spend a little more time with our patients through our movement practice, or even seeing them in physical therapy, we have a lot more opportunities to follow a lead or pick up on something, or a hesitation or a concern. And that will open up a whole nother way of looking at the patient. So I think it's really helpful.
Yeah. Now, we have quite a diverse set of answers coming up. I don't know if you're looking at the screen or not.
Yes.
But, and we certainly have talked about, some of our research on this webinar about the idea of voluntary activation versus spontaneous activation, versus positional activation. Just somebody sitting up and standing, that transition often can bring about a normal contraction. So I think we have a good idea of the diversity in answers from a good old-fashioned Kegel and a voluntary pelvic floor contraction. A lot of the imagery of lifting or holding to, hey, leave it alone and restore breathing and do normal alignment. So we're seeing a lot of that deviation. Anything jump out at you as you're sort of looking at these that, either it's like, oh, I want to bust that myth, or I want to, make this more popular, that more people know what we're talking about, or kudos to somebody.
So I think one of the things that has really gotten a little lost in translation is the pelvic floor cueing. So breath is a really important concept when teaching Pilates exercises, because we're working on maximizing contraction or elongation or any aspect that just to keep the patient focused, like not too far away from the same concept of in yoga, when you lose the breath, you are probably losing the movement. So, but in pelvic floor, I kind of look at the deep core muscles that the Aussie model, the folks that talk about the soda pop can, where you have, diaphragm, pelvic diaphragm, which is the pelvic floor, the deep transverse and the multifidus. Using that model, those guys are really silent partners that work together to regulate intra-abdominal pressure. And when you lay on different breath cues, you're influencing the intra-abdominal pressure. But for pelvic floor, the pelvic floor, just like those in someone who's healthy, normal developmental arc, those things should be coming in automatically and generally unconsciously. So my big thing is, we don't have to cue something that doesn't need help. It should be there in the first place. And then if we find a deficit through maybe discussing it with folks, or we see them doing some weird things like really holding breath or pushing or other dysfunctions, then that's when we should address it. And addressing it properly is really important. So I think one of my pet peeves is always using the cue of the breath, because when I see people in office, for example, they're doing all these inhalations to do a pelvic floor contraction. And that's not, when I have the ability to actually physically check intravaginally or interrectally if they can squeeze their pelvic floor. And the breath really doesn't have much to do with being able to contract those muscles. It can influence it, sure, but it's just a means to an end to maybe get people thinking about it. But at the end of the day, the pelvic floor should become unconscious to conscious and then conscious to unconscious again, and shouldn't be cued directly.
Yeah, one of the things we saw when Hadar Schwartz and I were collecting that data, just looking at voluntary contractions with ultrasound, looking at breath with ultrasound, we referred to it as mechanical because we didn't want it to be a contraction. What happens when you take a deep breath in, you're expanding the soda pop can, and when you exhale, it comes back in. It's just the natural sort of flow of tide of natural breath. And then we looked at spontaneous of an activity like sit to stand, like what happens when you just stand up, how does the pelvic floor react? And it was amazing what we saw. I don't know if you remember those stats where, and I think this is important for us to define, when people think that they're using breath to contract a muscle other than the diaphragm, versus using breath to possibly relax a muscle. So a lot of times when we saw, and I'm going to drill you a little bit about this one because I think we really need to break this myth apart, but the idea of that incontinence is always a weakness of the pelvic floor, and that's just not true. And so we had found a couple, and I don't know if you remember the stats on this. The last study we did was 45 female Pilates teachers, and we looked at those three areas, and we always have a 45%, no matter what country, no matter where we go over 250 subjects, that when people are trying to do an active Kegel or their imagery of a volitional activation pelvic floor, about 45% either do not activate the floor or push it down. So using other muscles than what they thought, or you'd see you might see the glutes kick in out in front through the ultrasound. We could see the glutes squeezing underneath the pelvic floor. But, and then we were at 95% had normal elastic displacement with breath. So I don't want people to think that, the breath was being used to create a contraction. Quite the opposite. The deep diaphragmatic breath, we would expect to see diaphragm drop down, hydraulic amplifier model that you're talking about from Norris, and pelvic floor drop down as well. There's no reason for the intra-abdominal pressure to go up. It's just maintaining normal status quo intra-abdominal pressure while we're doing whatever, and breath always changes intra-abdominal pressure if it's coming from the diaphragm. So to maintain normal, it's going to be this simple ebb and flow. But it was interesting that the two individuals that were unable to do the volitional contraction did not have displacement with breath and did not have a spontaneous reaction with sit to stand were women who were holding their abdominal walls in all the time. It was as if they had their own contraction. They were in their 20s, never had children, and they both said that they had problems with stress incontinence. Yeah. So it's very interesting. And I'd love to have your thoughts on just that, just hearing the stats. Like, how does that resonate with you or not resonate with you, and what you know and what you see every day with women who are dealing with pathology?
Yeah, I think that sample of patients and your discussion of them just now really sums up what we see in the general population coming into practice here. So we can have patients that have very strong abdominals, and it's almost like they've blown out the bottom of their soda can. So they've had prolapse, they have weakness maybe at the pelvic floor, or conversely, they have hypertonicity. It's so locked and loaded, there's no displacement even on simple inhalation. So that's a pathology we see all the time. And I think people forget that there is this ebb and flow between the two diaphragms, and that's really important because you're just managing that intra-abdominal pressure, and you can't generate stuff by holding breath, by pushing through it. That's not going to elicit pelvic floor, as we know. So we want, that's why I almost say it's better not to cue someone than to cue them sometimes, because then you're going to let the body do what it naturally knows how to do.
Yeah, and that's certainly what we saw. I mean, we were playing with a couple of the Pilates exercises, and Pam, by the way, uses all Pilates in her therapeutic exercise in her practice, and has a beautiful facility, beautiful teachers there. One thing we found was doing the high kneeling hamstring one on the chair. We didn't have to do any cueing other than to keep the femurs vertical. That we had 100%. If you could do the exercise, you had a natural and spontaneous pelvic floor lift when the pelvis passed a certain fulcrum point on top of the femur. Just sort of like what we would see with a sit to stand. Like there's a certain point, it just sort of, it comes on and off, and it's too fast to do a voluntary contraction. And I think this is the same thing about incontinence. Stress incontinence is, even if you're doing volitional training of the pelvic floor, the sneeze, the cough, the jumping, the running is happening way too fast for a voluntary contraction to prevent it. And I'd love for you to talk a little bit about the idea of, what is the latest out there with dealing with stress incontinence, and what are some of the, the latest research? What do we know is not working? What are some things you do as an internal therapist to be able to understand that better?
So from a functional standpoint, we don't have a lot still in the literature that is functionally driven. So I'll just put that out as a disclaimer for myself. A lot of stuff is still in case study format, not in RCT studies,
okay.
Random control studies. But what we can talk about is, just like anything else, people assume, and that's the big part, the assumption, just they're told to do a Kegel. And what does that really mean? So Arnold Kegel back in the 50s divined a perionometer, which was a device that was inserted into the vagina that was flexible. And the women that had stress incontinence were given this device it looks like a blood pressure cuff device, how you would measure blood pressure, and you would squeeze it, and the needle would go up when you had a good squeeze. So you, instead of pushing it out, which would not register anything on the device, you would then get the biofeedback from that to getting a contraction. So Arnold Kegel really focused on strengthening the pelvic floor universally to help with stress urinary incontinence. And usually at the level of the urethra, there's this layer 1, layer 2 muscles. Actually so here's a picture of the, just without the skin, right? Then we have our pelvis, and these are these very small muscles. And on the other side is collagen here that is very strong and not very elastic, because you want to keep this from moving around a lot. And when the pelvic floor is strong, it can act like a trampoline and rebound with the intra-abdominal pressure that's coming down to meet the bladder and other organs. And this is the end point, because the anatomists say that this and the other part of the pelvic floor, the levators, are your main postural muscle and what holds your innards up as we walk around and give us continence. So coming from where he identified squeezing these muscles led to improvement in your stress urinary incontinence, we're still now 50, 70 years later, still talking about Kegels. So I really call them pelvic floor muscle exercises, because there's a lot more dynamics to it. And at Herman and Wallace, where I do, where I'm been teaching for many years as well, we teach the exam to look at these muscles and look at them from the vaginal side, the rectal side, and a bunch of other information regarding diagnoses. So we're moving beyond this simple squeeze and release. So we know that the pelvic floor are mostly slow oxidative fibers, 70 to 80%. So if you're just teaching a quick on off, even in a cueing situation, you're not doing the majority of what these fibers do for a living. And a sneeze, though, has a very quick component. You have to be quick to get there to beat the intra-abdominal pressure. So you do have to cue for that as well. So I guess in our practice, I would say I've become way more identifying what part of it all squeezes together. It's all innervated by the pudendal nerve off S2, 3, 4, but with proper tactile cueing, verbal cueing, and getting the person to understand functionally, like anterior, like moving into a little anterior tilt. So I can even say out to the group right there, sit in neutral, perform a pelvic floor lift, feel where that feels in your body. Is it more rectal? Is it closer to like the midsection of the perineum near your sit bones? Or does it feel up front? Then take a moment and lean back in your chair, almost a posterior slump, squeeze again. Where do you in your brain register that portion of the contraction? Remember, it's all contracting the same, but your sensory awareness is going to be different. And then finally, roll forward towards the front. And I give cues of pick up a blueberry with your vagina, or in men, lift the penis, or in another way of thinking about it, lift the clitoris. So if you're looking up front, you're going to feel perhaps the 3 different areas of the pelvic floor, and stress incontinence may be affecting more up front. So we could give that more anterior cue. Now that has nothing to do with breath. It just has to do with the squeeze and the isolation of the squeeze.
And
So
along those lines, I mean, you bring up a couple of really important points. To me, the one that's the biggest is how little we know about our pelvic floor anatomy in general, and especially women. I've read a couple papers now, just, how many women have no idea what their genitalia looks like, and they don't want to know. And it's sort of like a taboo, and heaven forbid you say the word clitoris or vagina in mixed company. It would be the death of them. And that still exists in a day where we think that we should understand parts of parts and anatomy is anatomy. One thing that I would love to have you explain a little bit more, and that is the relationship of the sphincter muscles we're talking about, both the anal sphincter and the urethral sphincters, as in comparison to, we're going to talk a little bit about prolapse, which would be a vaginal wall breach, the muscle of the vaginal wall, as well as possibly the pelvic floor. But understanding the different muscles, like I know one of the things that we noticed when we were ultrasounding, and after looking at hundreds of them, it was sort of realizing, it's not that they don't have an active contraction of the pelvic floor, is that they think the vagina muscle is lifting the pelvic floor. Or so you might see a little bit of activity in the vaginal wall, but we wouldn't see the pelvic floor lift up. Or some of them we would see the glutes squeeze because they weren't quite sure where the pelvic floor was or what the muscle was that they were lifting. And others were using cueing in their own mind of things like stopping the flow of urine, which, again, thinking of that integration you're talking about, I would love to have a little more expansion on that relationship of the sphincter, particularly the urethral sphincter with incontinence and its relationship to like the pubococcygeus and the pelvic floor, and how do they relate in the sense of incontinence or continence? We could look at it a positive way.
So what we really need to know is that part of the musculature is under autonomic control, meaning that our urethral area is on close, tighten, and that is mediated through Bradley loops going up to the brain. And when we go to the toilet or decide to squat and pee, then we tell the brain, okay, go ahead and relax. And through that complex system, the autonomics release the intrinsic sphincters, and we release our volitional sphincters, which are here. So it's a very coordinated effort. That's why potty training takes so long for human children. And what's important to know is that the autonomics are working to keep us continent, because we don't think about contracting them all day long. Otherwise, we wouldn't be able to function.
Right.
So what we do have control over is the override in the volitional set to maybe delay urination at any point, or with that cueing I just spoke about up front, getting more where the urethra is, more to this section in layer 2, where all of that pouch is, you can elicit more direct contraction to really tighten and reinforce around the urethra if you've had damage from an obstetrical tear, for example, or maybe you've had decades of chronic coughing due to allergies or some other COPD or pulmonary issue, or you have bronchitis and you've really blown out a lot of things over weeks. So you can reinforce the contraction and help what's already happening in the autonomics by adding to in this deeper, in all the layers basically, but the volitional muscle set versus the autonomic set.
And let me just clarify too, Pam was talking about the autonomic nervous system. That's the sympathetic and parasympathetic nervous system that we often hear about, and how they work together in antagonistically, usually, to either maintain homeostasis. So whether it's the automatic way of maintaining blood pressure or digestion or reproduction, urinating, defecating, sweating, all of those things, we don't think about them. And breath is a complex one because breath has a subconscious autonomic component to it. We don't think about breathing at nighttime, but we can overlay and send a message that we want to take a deep breath, and we can do a volitional breath, or we can do that through moving the rib cage. So the pelvic floor has a lot of the similar qualities of how the vagus nerve and breath works with the diaphragm. And it's also intercostals, and it's also exterior muscles, and it's also positional movement of the rib cage or the shoulder girdle. Likewise, the pelvis, you were talking about the position of the pelvis, might bring a different level of load or awareness to different parts of the tissue, even though it's the pudendal nerve, even though it's the mixture of autonomic with, volitional.
Yes, and the because it's coming out of T10 to L2 on the autonomic side, and it's coming out of S2 through 4 on the volitional side. So it's an interesting concept, and that's why this goes back to my little pet peeve that you don't have to inhale to contract your pelvic floor. In fact, that should spontaneously occur volitionally whenever you want it, regardless of where you are in the breath cycle, in a way. Yeah. So that's something that you would just layer on it while you're running on your 5K run. You're not thinking about contracting your pelvic floor, nor should you be. It should be working for you. But then I'll have people that say, I only leak when I run. So how do I train that? Well, this is a very relevant question, right? So, and this is where I find Pilates very effective, and also moving away from that Kegel, because we have to increase the endurance of the muscles, because they may be fine for the first 100 feet, maybe 1,000 feet of that run, but after that, then they start to have issues. So again, finding out when things occur is always very important when it comes to pelvic floor health and the functional problem that they're having. So if I have someone that has particular problems with running, I'm not going to teach them to do pelvic floor exercises laying down in bed when everything is quiet and good, because that's not when they're not having an issue then. So you have to train in the environment that they're experiencing the dysfunction. So we bring them up into the developmental sequence or challenge them in different places along that line. And Pilates is awesome for that, because you can treat someone in supine. You can make the exercise extremely easy or extremely hard. You can treat them in sitting. You can treat them in quadruped. You can exercise them standing. The Pilates environment is there's so many variations, and you can make something so simple yet so supported versus so difficult and so not supported, with a lot of variation in the movement that can mimic the functional activity.
Yeah,
so that's what
I love that approach. That's how I see movement in general, is like, we're not treating through isolated muscle contraction. We're treating through body's orientation of a task in an orientation with gravity or other loads that are part of our function. And if that function isn't working, how do we go back and re-educate? Well, as Pilates teachers, we can go back and lighten the load and still keep a similar movement structural pattern, right? A motor pattern, and gradually increase load until they can do the activity. And that is the beauty of it. There was one other little question I had before we move on to another topic, and that is just looking at when we see hypertonicity incontinence, related incontinence versus hypotonicity incontinence. Can you maybe help bring some light to that, of just how it can happen with both? How could something that's over tight be incontinent versus something that's flaccid be incontinent?
Right. So the pelvic floor has to sort of be in this middle ground with an ability to contract and be tighter or create lift. That's why it's called the levator ani, because it's lifting the anus. That's how the anatomists talk about it. But if this, I use that hammock trampoline kind of metaphor, so that if your trampoline is super tight, it doesn't have a lot of range of motion. And if a muscle stays in a position of not a lot of motion over time, say an arm in a cast, those muscle fibers will become limited in their range and inherently will grow less strong when we gradually take them out of the cast and we create new range of motion. The new range of motion is very weak by comparison. So something that's short and tight, which the pelvic floor can be inherently weak then. It's not going to be able to react to those intra-abdominal forces or to the physical jarring of the body or to contraction of, say, the abdominals really abruptly, or someone picking up a load and pushing air right down onto the top of their bladder, because the support below is not as strong as the force above. Right. So someone who can be short and weak can have incontinence because they can't make a contraction more. They're limited.
Yeah. And maybe a way, and I've never thought about it in particular that way, but think of how we teach strength training of just a simple bicep when you're in active insufficiency. There's no strength here compared to what would be at 90 degrees.
And that was exactly the term, active insufficient. You're actively insufficient because you're in total contraction. So I have a lot of patients who cannot feel their pelvic floor per se, because it's so jacked up, it's not here. Once we release it, then they're like, oh, now I know what you want. You want me to let go so I can contract again. And they may have been self-helping themselves, like women may have stress incontinence, so they end up holding on to prevent the leak. And then that almost becomes a chronic holding situation. And then there's the loss of range of motion and loss of strength.
That's a great explanation. I'm taking little notes here on the side because I think, we look at anatomy and movement with all of our tissues. We look at things like we talk about contractures, right? So like you talk about the cast, you leave a joint in a cast for more than 6 weeks and you will end up with some soft tissue contractures.
Yes.
And somebody who holds their abdominals in all the time. And that was the other thing we noticed was they couldn't contract their abdominals. They were just shortened and not very strong and not very efficient. And yet that posture limited diaphragm from doing its normal thing, it limited digestion. They suffered from constipation. I'm sure they were not eating appropriately just because they were dealing with like a 22-inch waist that they were trying to aesthetically be pleasing in their own mind in the mirror. But they were young, never had children, incontinence, constipation, respiratory problems, who knows what else. So again, that almost fanaticism of thinking of powerhouse, or I got to have a stronger pelvic floor, or I'm going to be the woman that can shoot a ping pong ball 100 miles an hour across a room. There's these weird expectations. There's a question that came up for us, Pam, and Marion Rowe asked about estrogen in postmenopausal women, if that contributes at all to incontinence.
Sure. Estrogen is super important for muscle proliferation and also for blood supply. So when the muscle has less estrogen, as it does when it goes through menopause, it tends to have atrophy. Women tend to experience dryness in the vaginal mucosa. So penetration becomes uncomfortable. Even getting a speculum exam that formerly wasn't uncomfortable that was not uncomfortable becomes uncomfortable. So estrogen is just that secret sauce to keeping the tissues fluffy and vibrant and able to build more rapidly. And when we have someone who's menopausal, building muscle is more difficult. And you see that in all skeletal muscle. We're losing 3% of that muscle mass just as an aging process over the lifespan. So the same idea of adding back maybe topical estrogen to the vagina, that can help urinary incontinence, that can help the sense of dryness. So if the person's appropriate for that, that's why the estrogens really do help the muscle and improve incontinence, because the actual urethra, which can get dry at the terminal end, at the meatus, where we're seeing when there's lack of estrogen in that area, the law of physics, where there's hydrophilic and the urethra can collapse on itself to create continence, it deteriorates because it becomes more dry and there's more room for the urine to leak out. So as simple as that. So yes. And then I just want to go back to finish that one thought on the breath. So it's not that I don't want people to think you can't breathe to get the pelvic floor contractions. Sometimes you can teach the transverse contraction with the shh or the inhalation, which I'm still also, I have many thoughts about that, because I'd love people to move past that and get it spontaneous. But one thing I do highly recommend is the breathing assessment, because if you see someone not able to move the column of air from chest down towards the belly, and rib expansion, both in the anterior, posterior, as well as the lateral, it's a 3D. We have, those 9 lobes that have to get ventilated. If you have someone who's an upper chest breather, the diaphragm is not in that much of an excursion, and the rhythm of the diaphragm, pelvic diaphragm is constant. It's a little sine wave going on throughout the day.
Yeah.
And those folks are losing those repetitions of the pelvic floor in sync with the diaphragm.
Yeah.
So the pelvic floor becomes dysfunctional in a way. And I see down the line, I've anecdotally, I'm starting to collect data on this, is that when you have mostly upper chest, a scenario where the person is an upper chest breather, they have a higher degree of pelvic pain because it leads to less range of motion in there, less awareness of the pelvic floor, and they can't make the connection volitionally as well as autonomically, in my opinion. So there is something that to be said about fixing the breathing. Instead of cueing the breath for the pelvic floor, I say, just stick straight with good breath control, and you're gonna get that automaticity to pop in.
And that was the same conclusion that Hadar and I had come up with when we realized, we're looking at, and we taught this fascially as well. We talk about elasticity. Like a lot of times we think of tissues as being contractile, but as you just explained, that sort of ebb and flow of the two diaphragms, and I would include the vocal cords as well, but the different diaphragms that are, maintaining intra-abdominal pressure dynamically based on our daily activities spontaneously in a healthy individual, right?
Yes.
And so as long as the tissues are being moved, they maintain their elastic properties.
Yes.
When they stop, and that's what I hear you saying, is when we stop moving it, we're going to lose the elasticity. It's going to get weak. It's going to, it's not going to have that normal elastic. And I think it's the elasticity, now that I'm thinking about it, that really probably is one of the best preventers of incontinence.
Absolutely.
That would be stress incontinence. So not necessarily talking about somebody having a major surgery or right after partum, but that idea, like when you talked about the just the hormonal drying out of the pelvic floor and the urethra and the sphincter, that really made sense to me to think that, well, if those tissues aren't supple and aren't moving in a normal way, just as we move our body, it's the same thing. We become sagittal beasts sitting in a chair, and we expect our back to be able to move in 12 degrees of freedom, and it doesn't. Well, it's no miracle. We've been sitting in a chair with no demand on it. Or another good example is ankle dorsiflexion. We put a kid in a chair at 4 years old. They no longer have to put load through their ankles unless you make them sit on the ground, especially as they're going through their growth spurts for the next 10, 15 years. So if they go through growth spurts and they never go down into a deep squat, they'll never have that elasticity and that mobility that we need in our ankle dorsiflexion to have healthy knees, healthy hips, healthy back. It all ties in together. And that's what I wanted to sort of bring out is, we don't have to make the pelvic floor like it's some kind of foreign Martian tissue. It's responding just like any of our muscle tissues respond, any of our organs respond. And, when we understand that, and we understand that movement, normal breath sometimes can be the very best thing that we can do. And that people that are sedentary and people that are immobile or people that are fearful of moving, there's lots of reasons why they wouldn't move. Pain, right? They could be in pain. We haven't talked about pelvidynia, but pain in itself can stop movement, stop breath from going down low. It might make somebody with severe pelvic pain might just resort to accessory breathing because they don't want to have any displacement down there, or if they have, those kind of things. So that's really cool. We have another question. I think we've answered this one already, Christine. As far as suggesting for bladder leakage, that's the incontinence with sneezing. And we've sort of talked about just maintaining that elasticity and the suppleness, the movement, natural breath, natural movement. Is there anything else that you'd want to add to that, Pam, before we go on to like prolapse and talk a little different anatomy pathology?
Just to add in, if someone has true stress incontinence, for the person to actively recruit and understand where the pelvic floor is, that may need to be referred out for further, to a good pelvic health PT who can identify where it is with the patient or with the client, and then get them to actively do that. And then they practice doing it with that intra-abdominal pressure load, during volitional activities, even ballistic movement, which ties into the prolapse piece too as well. But you're training it for, like for sneeze, I just say squeeze before you sneeze. So and that's not the butt, right? It has to be lift the urethra. So aiming for the front.
Yeah, very good. Let's go right into talking a little bit about prolapse and maybe explaining what a prolapse is. And there's lots of different things we hear about prolapse. Which organ?
I think, I wonder if I can show my,
if you take the blur off, we'll be able to see it.
Yeah, I think I'm going to do that and show just the difference, because people think oftentimes that they have a prolapse, like that their insides are falling out. Yeah. So more times than not, though, it's just the bladder settling in to the front of the vagina. So it's not the easiest to see, perhaps. So let's just do a little, you can see that this is the bladder, that big elongated piece, and this is posterior. And in the middle is the vagina. So people notice something at the opening of their vagina, and it looks like a ball. And they say, oh, something's falling out, or they feel this pressure. And with a cough or sneeze, it may even bulge a bit more. So a cystocele is when the bladder pushes into the anterior part of the vagina. And that's a support issue. And that's commonly seen with women who have had children, vaginal births, where they're pushing for long periods of time during the pushing stage of labor, stage 2. It also comes with people who have very poor lifting technique, like with weights. Also comes with that chronic insult with lots of coughing and other types of things. So people that are maybe not using the proper lifting mechanics, or even sit to stand with good leg muscles, I see that a lot. They have no abdominal control. They have very weak glutes and lower extremity. That puts a lot of pressure on the pelvic floor, because that's the last vestige of holding your insides up. And all that pressure is coming with no support from the other players, and then the bladder just continues to push down. So the nice thing about a prolapse is that if they're a grade 1 or a grade 2, grade 1 meaning very little movement, grade 2 meaning that the person can see it at the opening, but it kind of goes away. Like in the morning when they wake up, they can't see it. It's after they maybe exercise, or after standing for many hours. Yeah, at the end of a day. So those can be reversed with improving technique, breathing, exercise technique, breathing technique, and exercising the pelvic floor so that they're more supportive of that. So, and the biggest thing is constipation. You'd be surprised how many chronically constipated people end up with these prolapses. So you can have the cystocele, which is here with the bladder pushing into the vagina. The rectocele is when you have the rectum pushing into the vagina. And I think more people have rectoceles than we think, because they have the sensation to go, but nothing comes out, because it's kind of stuck off to the side instead of in the path. And this is a defect from chronic straining and having hard stool that just keeps going in the wrong direction. And it's much easier to prevent rectocele than it is to repair it, I would say. I think colorectals would agree. It's always good to keep the tissues from getting lax there so that you don't have that. So getting away from chronic constipation, having a good diet. So it kind of goes back to everything in the beginning. If you eat well, exercise moderately, have good toileting techniques with being able to assume a squatting position, or and use a lower toilet rather than these ADA toilets that little kids are toilet trained on with dangly legs. Bring out the squatty potty. I have no interest in squatty potty. I wish I would have developed it. I didn't bring it to market. So
I love the commercials.
Yes, they're very funny. I give them all the credit in the world. They solved a problem. So prevention is so, it's an ounce of prevention is worth a pound of cure here.
So we got a couple questions up, and then I want to talk about when it's a stage 3 or stage 4, it needs surgery, they do a mesh. How do we as Pilates teachers respect that? So we'll come back to that. Let's look at these two answers.
Okay.
One is hyaluronic suppositories for vaginal muscles as well as estrogen suppositories. Any experience with that or comments on
Yeah,
that?
so I'm not a medical doctor, but I can tell you that hyaluronics, just like it is for the face, you know, they've used that, and for joints all these years, they're finding that hyaluronic acid suppositories provide nice moisture alternatives, especially for people who are not going to take an estrogen type product because of a cancer history. So the efficacy is good. The gold standard, I think, is still estrogen, but hyaluronics really can add a lot of relief for intercourse and just the feeling of, and beyond intercourse, any kind of sexual play where the vagina is involved, because it will reduce any of that irritation. And
then the next question from Yvonne. Hello, Yvonne Cruz.
Hello, Yvonne.
I remember Yvonne. Is, you know, this is some of the common kind of, you know, when we don't understand anatomy fully, sometimes we're trying to make sense out of how do we get that that UTI and how did that happen? But here's the question is, does the rectocele actually cause the bacteria to go into the vaginal wall? And that's...
So I would quickly jump in to say, great question. So glad that you're here, Yvonne. That's a great question. But remember, prolapse, we're evidencing the vagina mucosa. That's what we see. And the defect is actually in the organ. So they're in separate tubes. So as it is, urine is up in the bladder. And if the bladder's falling into the vagina, it wouldn't cross unless you had a fistula, which can occur. But that's a little tunnel that develops over time. And then there can be bacteria that crosses between the two organ places. But the rectocele would be in its own place. But more importantly, especially in women, those holes are very close together. So the urethra is in the top of the vagina, and then the vagina is very close to the anus, and not everyone's perineum is the same. Some people are closer together, some people are further together. Aging may change that, childbirth may change that. So it's easy to get cross-contamination from the front to the back and vice versa. So
and even things from surgical procedures, hemorrhoids, all kinds of things that can sort of pack, you know, E. coli around the area, that even underwear can transfer the E. coli easily into the urethra, and hence UTIs and stuff. So, well,
the tolerance of those tissues all of those organisms are everywhere in our bodies, and it's just keeping the proportions manageable. So
no colonization.
Yeah.
Wow. You know, we've gone 50 minutes, 55 minutes straight, and we've just barely scratched the surface. We haven't talked at all about partum or postpartum or diastases that often accompany that. We get that question quite a bit. So we're going to have you come back again, Pam, which is going to be fine. I always love talking to you. In the last 5 minutes, is there anything else that you'd want to share with the folks on the Polestar Hour?
Yeah, I'm just so happy to be here and talking with you guys, because I'm always preaching to the choir. I think the big take home is, don't worry about cueing the pelvic floor specifically, but do the good cueing that you're doing in the exercise itself. My hot hits for improving incontinence that I use when I exercise my patients on the equipment are doing standing on the reformer and doing both. Yes, out and in, because the in is going to facilitate the pelvic floor. The out is always good for stability of the pelvis, which we need. So that's one I use a lot of the time. And another one that I think is really important for us to understand is lumbopelvic hip dissociation. And when you can separate the hip flexor dominance in certain clients, away from glutes and hamstring deactivation, so to speak. That is going to improve continence, because all of a sudden now the holding and the guarding of the external rotators diminishes and opens up a lot of more interplay of the pelvic floor with the surrounding pelvic musculature. So there is a plethora of exercise we can do on all 5 pieces of equipment, including the mat, to do lumbo-pelvic hip dissociation. And you can go from knee fallout being super easy to super complicated. So I don't have to tell you guys, because I rarely work at that advanced level. So there's a ton of stuff you guys can do out there and have a lot of fun with your clients, challenging them at all parts.
Yeah, I appreciate that statement, Pam. And I think that, you know, in the big picture of things, we're looking at the continuum. And we're going to come across clients that are not responding necessarily to our Pilates. They might have something more severe, something that needs to be evaluated. And I just strongly suggest, like for me, even as a senior physical therapist, I know that I have Pam's knowledge available for patients of mine that have issues that I can't figure out, or that need more of an internal consultation, or her expertise. And I strongly encourage you, again, I guess you could use a Herman and Wallace sort of reference page as far as physical therapists that are trained in pelvic floor health, but to find some that are close to you and start building a relationship with them, because it's such a beautiful continuum with the Pilates that for women and men that are dealing with pelvic floor health issues that require physical therapy, surgeries, the more advanced. We talked a little bit about mesh. We didn't really get into it, but surgical procedures that will be returning to their normal function. So a lot of times each case is so unique. It'd be like me saying, Pam, you just got this person you're discharging. Anything I need to know about them and precautions or things to be worried about. And maybe they have some abdominal hernia meshes, or you know, they had heart surgery. These are always, it's the same thing. We ask the questions about the individual to the medical professional. And that shows that you are sensitive to their direction of what their patient can and can't do. We're respecting their knowledge in the big picture of restoring that person to their level of function and their participation. And as long as we see ourselves in that continuum and we can communicate with a continuum, it's in the best interest of the client. All right, well, we are out of time. Thank you so much, Pam, for taking time out of your busy day. I know how busy you are, and look forward to talking to you. I do have some new research that I need to talk to you about, but we'll come back to that offline. Okay. And thank you, everybody. We have, I'm sure we'll be seeing Pam's course emerge again in the next number of months. We have lots of exciting things going on. We will put the link in there for hermanandwallace.com. And for those of you that are interested in more training, maybe take a course with Pam in that area if you're a physical therapist. And then if you're a Pilates teacher, wait till we put it back out there with Pam in Polestar Pilates. And until then, today is a good day to be good. So be kind out there, treat people well. We certainly appreciate all that you do out there in the Pilates world, bringing peace and health and well-being to your communities. And we'll see you next week. Next week, I have Eric Franklin. Matter of fact, Pam and I went through Eric Franklin training together, didn't we?
Yes, we did.
Yeah, we did. And we were the first ones to bring him here. I'm going to take that claim to bring him to the U.S. And we went through that training very early on, learning to use a lot of Eric's cueing and
use it every day.
We both use it every day. So we're going to talk about, is there a perfect movement? And what does that even mean? And how do we facilitate that? So super excited to have Eric next week. Even if you can't make it, you should register for it so you can see it later. Tell a friend. Pam, thank you. We'll see you guys next week.
Thank you.